First, disclosure slides. There are a number of different pharmaceutical companies that I do consulting for. And let me say in advance that one of the main problems that we have in treating fibromyalgia, and more broadly in treating chronic pain, is we simply don't have very effective drugs. For almost every other medical condition that I know of in the last several decades, we have developed much more effective drugs for treating high blood pressure, high cholesterol, diabetes, congestive heart failure. But our drugs to treat pain have not really had comparable advances. In fact, a lot of the drugs we use to treat pain are derivatives of drugs that have been around for centuries. So one of the problems we have, not just in treating fibromyalgia, but more broadly in treating chronic pain, is we can't be as reliant on our medications or on our drugs as we can for a lot of other diseases. And so both Winfried and myself will talk, I'll talk about drug therapy, but we'll talk a lot about non-pharmacologic therapy and non-drug therapies that can be effective in treating conditions like fibromyalgia. So I want to start by presenting a case, because one of the things that I want to try to convince you of today is that maybe you've been thinking of fibromyalgia in not quite the right manner. The classic way of thinking of fibromyalgia is that fibromyalgia is occurring primarily in women who are middle-aged. They have a lot of trauma, a lot of stress, a lot of psychological factors, because that is the classic way that most healthcare providers think of conditions like fibromyalgia. But I'm presenting a case here, and it might be nice to turn the lights down a little bit if you can do that, just so you can see the slides, of an individual who has fibromyalgia, but if this individual, who was a male, was seen in a clinic in the United States, it would be likely that this individual would not ever be diagnosed as having fibromyalgia. Number one, because it's a male, not a female. Number two, because the pain is not so widespread that you immediately think of fibromyalgia. But both Winfried and myself will talk about this notion that instead of thinking of fibromyalgia as a discrete disease, as people that we've classically defined fibromyalgia, that instead we should think of it as more of a continuum, and that a lot of individuals who have chronic pain that we label as chronic low back pain or irritable bowel syndrome or chronic neck pain, in fact have the same fundamental problem as individuals with fibromyalgia, but we have historically really only looked for fibromyalgia in women and that have some of these other factors that we have historically associated with fibromyalgia. So, did you ever look at stuff and wonder how it got there? So do I. The talk that I'm giving today is normally a long talk that I give, and it is, for the session today, I had to break it into 3 sections. So every time you see another Trump slide, that means I'm about to leave the stage. It's my transition slide so that I know that I'm going to talk. But I had a lot of fun putting Trump slides together because I and most of the more intelligent people in the United States think he's a total idiot. Now, did you know that you are partly responsible for Trump? Whenever I go and talk in a foreign country, I try to learn a little bit about the country. This is an area up in the north of Norway. Pronounce the name? Troms. Okay. Did you know that you grow his hair? We've always wondered. We've been accusing him of having a toupee and everything like that. It's natural, but it's not really his hair. Yes. So I want to talk about the evolution of fibromyalgia and start off on the left side of this slide and talk a little bit about the evolution of fibromyalgia, and Winfried will expand upon the differences between some of these diagnostic criteria. That until about 5 or 6 years ago, we used the 1990 American College of Rheumatology criteria for fibromyalgia, and those are indicated on the left side of the screen. At that time, we thought of fibromyalgia as being a discrete illness. That means either someone has fibromyalgia or they don't have fibromyalgia, and there's nothing in between. We also thought that the tenderness in fibromyalgia was confined to certain areas of the body that we called tender points, and we actually made people count how many tender points people had in order to see if they fulfilled criteria for fibromyalgia. The criteria were that people had to have chronic widespread pain and have 11 or greater out of a possible 18 tender points. And you see all the little areas of the body, those red dots that are indicated as tender points. Before the advent of brain imaging and all the other techniques that I'll talk about in the middle session where we talk about pathogenesis and mechanisms, you could not see anything wrong in these individuals. So these really were thought to be individuals who were complaining a lot, had a lot of different symptoms, but there was really nothing wrong with them. And we erroneously blamed psychological factors for a lot of the symptoms that women with fibromyalgia were experiencing, because the old criteria diagnosed exclusively females. There were about 93% of the individuals who would have been diagnosed in a community using the old criteria would have been women. And so this was very easy to make this out to be this disease of psychologically affected middle-aged women. It was very easy to paint this picture of fibromyalgia. But then as research began to occur, our group and others started to show that there was nothing magical about these 18 areas of the body, that the entire person that has fibromyalgia is tender. So you move over from a person that has 18 areas of tenderness indicated by the tender points to this slide over on the right, where the entire person is more tender. If you push on the thumbnail or the forehead of someone with fibromyalgia, they will be much more tender than someone who doesn't have fibromyalgia. But those studies were also starting to give us clues that if the tenderness was so widespread, then it wasn't likely that there was some musculoskeletal problem or some damage or inflammation in the tissues that were causing that widespread tenderness, as well as all these symptoms that people with fibromyalgia experienced. And our group and a number of other groups started to look really extensively into the central nervous system, into the brain and the central nervous system, as where the origin of fibromyalgia is. And I think we have fairly conclusively shown that fibromyalgia is really a brain disorder, but much more so than it is a problem in the different areas of the body where people are experiencing symptoms. But another thing that we realized about fibromyalgia is you find individuals that would meet criteria for fibromyalgia or that have the exact same symptoms as those seen in fibromyalgia in groups of every other type of chronic pain. You find this in individuals with headache. You find this in individuals with rheumatoid arthritis or lupus. You find this in individuals with low back pain. Any chronic pain condition that you look at will have a group of individuals that have that same phenotype as we see in fibromyalgia, that although they might be coming in with low back pain, their pain actually is in many other areas of the body besides their back, and they have some of these other symptoms like sleep problems, fatigue, memory problems, that allow us to identify that that person's symptoms or that person's pain may be partly coming from their back or partly coming from their knee or partly coming from some damage in some area of the body where they're experiencing pain. But above and beyond that, they seem to have the same kind of fibromyalgia phenotype that we see in individuals that just have fibromyalgia and don't have an autoimmune disease or some other problem. So as someone who has moved from being a rheumatologist to being a pain researcher, the way we now think of fibromyalgia is that it's more of a final common pathway. It is central sensitization of the brain and the spinal cord. And that if we can learn in clinical practice to identify people that have this fibromyalgia phenotype, the widespread pain with fatigue and memory problems and sleep disturbances, then we won't just be identifying people who have fibromyalgia as a diagnosis, but we'll also be identifying people that have rheumatoid arthritis as their primary diagnosis, but superimposed upon that, they have fibromyalgia, and you have to recognize that and treat it, because they're not going to respond to just treating the inflammatory component of their autoimmune disease, or just treating that lesion they have in the back, or just treating the other fundamental problem that their formal diagnosis carries. And then once you start to think of fibromyalgia in this context, it's not just a pain disease. In many individuals, the fatigue, the sleep problems, the memory problems, the sensitivity to the brightness of lights, the loudness of noises will be just as bothersome as the pain is. Although most of us who study fibromyalgia are inherently pain researchers, fibromyalgia is not just a pain condition, and those of you who have fibromyalgia know that quite well, that in different times during the course of your illness, the fatigue, the memory problems, the sleep problems might be just as bothersome as the pain problems we associate with fibromyalgia. And so fibromyalgia has actually led to, in the broader pain field, us sort of reconceptualizing a fundamentally different type of pain here, which is centralized pain. We've known for a long time that people can have nociceptive pain that's coming from because there is some damage or inflammation in the peripheral tissues, or they can have nerve pain because of the fact that there's a pinched nerve or a damaged nerve. But it turns out that this type of pain is the most common type of pain in individuals under age 50. If you look at the conditions that are now thought to be centralized pain conditions, that would include fibromyalgia, headache, irritable bowel syndrome, interstitial cystitis, bladder pain syndrome, even low back pain now in the United States by the National Institutes of Health is put into this category of centralized pain conditions, because the majority of people with low back pain have more so a problem in their brain, their volume control setting in their brain that's causing them to have pain in their back, than they have a problem in their back that's going to respond to surgery or injections aimed at their back. But as we have thought about these three different underlying mechanisms of pain, just by understanding the clinical features of these different types of pain, you can get a good idea when that person is sitting across the exam room for you, which of these mechanisms is present in each individual, and what treatments are going to work, because the treatments we use are really aimed more so at the underlying mechanism of the pain than the underlying disease that might cause that. So if you look at individuals with nociceptive pain, where the pain is due to damage or inflammation out in the peripheral tissues, drugs like nonsteroidal anti-inflammatory drugs, opioids, injections, and surgical procedures are going to work fairly well for this kind of pain, because the problem in this kind of pain is in the area of the body where the person is experiencing pain. And these drug and non-drug therapies work best on damage or inflammation in that area of the body. If someone has nerve pain, and you can identify that by looking at a body map, and by the way, if I forget to say this, and I think Winfred will say the same thing, if you are seeing patients with chronic pain and you are not using a body map, you are not putting a body map in front of that person and making them fill out a body map, you need to. It is an incredibly useful single piece of information to look at, because I can look at a body map without even seeing a patient and get a pretty good idea of which of these underlying mechanisms of pain is present in a given individual. In individuals with nociceptive pain, you'll see pain in one or two locations of the body only. In patients with nerve pain, you'll see pain follows the distribution of that nerve. If it's sciatica, you'll see that pain starts in the buttock and goes down the leg all the way to the back of the leg. If it's carpal tunnel syndrome, you'll see numbness and tingling through the entire arm, and you'll see that people actually draw the distribution of the nerve. But if it is centralized pain, if it is the kind of pain that fibromyalgia is the poster child for, people will have far more locations of their pain, and they will have these other symptoms like fatigue and sleep problems and memory problems and mood disturbances that will go along with the multifocal pain. And a point of emphasis here is that we used to think that if we knew the diagnosis, was osteoarthritis, then the only kind of pain people with osteoarthritis had was nociceptive pain. And if we knew the diagnosis was a painful diabetic neuropathy, that the only kind of pain they had was nerve pain. And if we knew the diagnosis was fibromyalgia, the only mechanism was a brain mechanism. That's all wrong. In any of these diseases, people can have any of these three mechanisms. And so we know, and I'll show you some data in the next set of talks that I give, that 30% of people with osteoarthritis or rheumatoid arthritis or lupus have a strong element of fibromyalgia. And so they have both nociceptive pain and centralized pain. You have to identify both types of pain, and you have to treat both types of pain. Because if you look at that rheumatoid arthritis patient that has concurrent fibromyalgia and you only treat their rheumatoid arthritis with methotrexate or a TNF inhibitor, you won't make them better. They'll still have fibromyalgia even after you give them all those very powerful immunosuppressive drugs. But one of the analogies that I have started using to try to explain pain processing to people is that the amount of pain that a person is experiencing is like the loudness of an electric guitar. And if you think about it, we have sensory nerves that bring up qualitatively different information about what's going on out in the periphery. We have C fibers and A delta fibers and different fibers that are responsible for detecting heat and cold, and inflammation, and pressure. And all of these nerves are responsible for bringing qualitatively different information up to the brain to tell us what's going on in different areas of our body. And you can get the loudness of the guitar to be louder by strumming those strings harder. But the main determinant of how loud an electric guitar is what the amplifier is set at. And in this analogy, the amplifier for pain is the spinal cord in the brain. And we know that there are a lot of people in the population that have a knee x-ray that looks like this. In the United States population, 40% of people that have a knee x-ray that looks like this don't have any pain. And 10 or 20% of people that have an entirely normal knee x-ray have severe knee pain. And the reason that there's never a good relationship between what you see on an x-ray or what you see on an MRI and how much pain someone is experiencing is that people have different volume control settings or gain settings in their brain, which is their amplifier. And if you have a high amplifier setting in your brain, you can feel pain in your knee even if there's nothing wrong in your knee. But if you have a low amplifier setting, if you happen to be a pain-insensitive person, which I'm fortunate enough to be, I've never had chronic pain in my life, I've never had a headache in my life, and I'm not that unusual because only 1 out of 3 people in the population has any type of chronic pain, that if you happen to be pain-insensitive because you have a low volume control setting in pain sensitivity in your brain, you don't feel what's going on in your knee, even if you have severe radiographic evidence of osteoarthritis. So you have to add together, when you see that person across the exam room from you, you have to add together what's going on in their periphery, what's going on in their knee, and then what is their volume control setting or their gain setting. And the higher their volume control setting, the more fibromyalgia they have. And again, this is the metaphor that we now use in the greater pain field to think of fibromyalgia as being more of a continuum rather than a yes or no. This is another way of showing that if you look at a big group of people in the population and you do different types of quantitative sensory testing to see who are the most pain-sensitive people, the most pain-sensitive people are the ones that are most likely to develop new episodes of chronic pain over the next 5 to 10 years, not because they're more likely to damage their knee, but because they have a higher volume control setting in their brain. So let me show you what I mean here. Imagine any orthopedic surgeons in the audience? Okay. Well, I'm not going to make fun of orthopedic surgeons, so it would be okay if there was one here. If you're an orthopedic surgeon and someone comes into you with knee pain and they have an x-ray like that one on the right where there's no cartilage left and they have bone rubbing against bone, are you going to replace their knee? Are you going to put in a new knee? Yeah. In the U.S. we would. Seems like a very reasonable thing to do. That may work very well, but imagine that that knee was in this person. Are you going to make them better by replacing their knee? Okay, so what I'll do is show you data in the next set of talks that you shouldn't just think of the two extremes, that everything in between is important, and that people that have different degrees of fibromyalgia or fibromyalgia-ness, which is a term that was coined by Fred Wolf about 20 or so years ago. I don't agree with hardly anything that Fred writes in the literature, but he got this right. He got fibromyalgia right, and that is that we shouldn't be thinking of fibromyalgia as yes or no. We should be thinking of it as more of a continuum, because he showed, starting 15 or 20 years ago, that the degree of fibromyalgia that a patient with rheumatoid arthritis had was a stronger predictor of how much pain they would have or how much disability they would have than their sedimentation rate or their x-ray or some of these other more objective measures that we consider to be really what rheumatoid arthritis is or what osteoarthritis is. And so it was Fred's early work showing that we should think of fibromyalgia as a continuum that led to a lot of the work that I'm going to present later with respect to the pathogenesis of fibromyalgia. And these are the new 2011 criteria for fibromyalgia, which look at how widespread someone's pain is, and then whether they have fatigue and memory problems and sleep disturbances, and give people a score that is a score of where people are on that continuum. You can put a cut point in that score and say if someone has a score of 13 or greater, you give them the label of fibromyalgia. But what I want to try to convince you is that that's not really the best way of thinking of fibromyalgia. It is far better to think of this as a continuum, and that fibromyalgia is really the end of the continuum. So I don't know where my Trump slides went. That's tragic. Don't worry, I have Trump slides. I'll make sure that they're in the talk for the... so now I think I will turn this over to Winfried, and he will continue to talk about diagnostic criteria.